So first, hello everyone, welcome to Aohua Vet's webinar. I'm the host from Aohua, and our company was established in 1994, and we focus on endoscopy system for almost 30 years. And our goal is to make endoscopy diagnosis and treatment more accessible and convenient. And Aohua Vet has monthly webinars on Zoom and also clinical cases on YouTube. And we aim to bring all the veterinary endoscope users together to share their knowledges and experiences. So just feel free to ask any questions in the Q&A chat box. Don't miss this opportunity. It's very precious. Okay, next. Let me introduce our old friend, Dr. Vasiliki, today. She is qualified from AUTH Greece, and her clinical interests including canine and feline gastroenterology, nutrition, and diagnostic, interventional endoscopy in companion animals. She holds a GP cert in small animal internal medicine and a GP cert in endoscopy and endosurgery from the International School of Veterinary Postgraduate and a PG cert in small animal medicine from Harvard Adams University in UK. And also she is invited speaker in multiple seminars, webinars, and also a trainer in gastroenterology and endoscopy courses in Europe, Middle East, Africa, and Turkey. And she also awarded by AASCO. So I will give the host to you so you can share.
Thank you, Jason. Thank you very much. I welcome you all to this 8th, I think, Jason, webinar. And I'm seeing also, please check the Q&A box so that you can answer to people as well. I welcome you all. It's a huge pleasure. Today we're going to talk about a bit of interventional endoscopy, because up to now we were talking about more about diagnostic procedures. So we're going to talk about a very, very dear to me topic, which is balloon dilations and strictures in esophageal strictures in cats. Before starting, I want to thank Aohua for the opportunity to come in contact with you. Whichever questions you might have, just put them not in the chat box because that was disabled, in the Q&A box. And also, please do not forget to mention your preferred time, if it's more convenient to do the webinars during the evening, or if it's more convenient for you to do them in our scheduled hour around noon, so that we can schedule it for the upcoming events. So let's talk about stricturing. We're gonna just be doing and reviewing cases in the feline patients, not in dogs, because for cats, esophageal strictures in cats are have a multiple etiology and causes and origin, and we're going to go through that and explore it. So let's first talk about how the normal esophagus is, and I know that a lot of you who attend these webinars already scope, but let's just do a bit of refreshing. So the esophagus has, the normal mucosa of the esophagus is pale, pink, smooth, and glistening. It's a lumen that's even, does not have granularities, does not have lumps and bumps. So in normality, it's a very, very smooth lumen. And of course, it doesn't contain any food, any fluid, or it shouldn't contain any food or fluids, bile or gastric contents. It could be, it could have some small amounts of saliva. But if you see esophageal content, then this is pathological. We can see the tracheal indentation as landmarks in the first part of the esophagus. The tracheal rings sometimes are visible. Watch out, don't overinflate your ET tubes because they're really prominent in the esophageal lumen. It doesn't make your procedure more difficult, but it gives you a hint that you have overinflated your ET tube. Okay, of course, always under sedation, your procedure, your esophagoscopies, okay, general anesthesia and intubation. So under sedation, we could have a mild peristaltic wave. Most of the time, the lower esophageal sphincter is closed. And in cats, we have a better visualization of the blood vessels. I'm going to show you some scopes, some endoscopies of normal cats. And the very, very characteristic part of the feature of the feline patients is that in the distal third of the feline esophagus, we have these rings, these transverse folds that are associated with smooth muscles. So this is how it looks. This is the last third of the esophagus in cats, okay? And you see how prominent the vessels are in cats. So you can easily distinguish between feline and canine patients, even if you don't see the outside and you only see a lumen. And let's go and see how a normal esophagus looks like. So you see the vessels here that are really prominent in the cat. In dogs, you cannot see the vessels. This is not pathological here in this cat. And you can see these transverse folds, these rings in the distal esophagus. The lower esophageal sphincter should always be closed, so watch out your anesthesia. And also, this is not gastroesophageal reflex. This here that we were seeing before, it's the Z line. So please be cautious into evaluating the Z line as esophagitis, as gastroesophageal reflux disease and consequent esophagitis. And what about the esophageal stricture? What is an esophageal stricture? Most of the cases that come to us are admitted with an already formed stricture. So there is no active esophagitis at that point. There is this fibrous connective tissue already formed. And the definition is the pathological narrowing of the diameter of the esophageal lumen and the production of fibrous connective tissue, which is very, very strong and hard and very, very difficult to dilate. If you're very lucky and you touch it in the beginning, if you're aware of the disease, and you might, for example, you have a cat that has been chronically vomiting, or a cat that has undergone a surgical procedure during the last 2 weeks, for example, and this crosses your mind as a differential diagnosis for a regurgitating cat, or for a vomiting, as the owners will say, cat, then you have the chance to intervene very, very in an immediate way. So as you see here in the X-ray, we have a dilation cranially to the stricture. This is the stricture point. We have a dilation of the esophagus, which is a megaesophagus actually, but it's a mechanical phenomenon here, and it's not a functional megaesophagus. So we have a dilation of the esophagus just proximal cranially to the stricture. And of course, some of the contrast medium passes through the stricture. And this is the stricture. And you can see this band, this whitish band, that's the connective tissue. And you see how dilated the esophagus is just behind this band. I'm not going to talk a lot about pathophysiology, but I always like this hydraulic, phenomena. So it all has to do with the viscosity, the length of the tube, and the pressure difference. And this is how the flow is determined, actually. We have a differentiation of the strictures depending on whether they are benign or malignant. So benign strictures may occur after severe esophagitis due to chronic vomiting, due to gastroesophageal reflux disease, due to foreign bodies, and then after the removal of foreign bodies. So these are benign strictures, esophageal strictures, drug-induced as well in cats, as we will say later on. We also have malignant strictures from a neoplastic tissue that's proliferating and obstructing the esophageal lumen. There's also a distinction between congenital and acquired, intramural and extramural. And of course, extramural strictures are from outside, like, for example, vascular ring anomalies, or sometimes we have enlarged lymph nodes in the lungs that are compressing the esophagus from outside. And beware of the last category, because we can have one single stricture lots of the times, most of the times, but we can also have multiple strictures, especially in cats. So when you're done with dilating one stricture, please go through the whole length of the esophagus and check, because you might have another one, especially when you have gastroesophageal reflux disease or intractable vomiting that cannot be controlled with any means, with any antiemetic. In this case, you might have esophagitis up to the pharyngeal sphincter. So in these cases, we might have multiple strictures along the way, along the length of the esophagus, and be aware of that. So what are the clinical signs? Most of the animals that are admitted to our clinics have progressive regurgitation. As I told you, some owners might think that this is a vomiting, that these are vomiting episodes and that are not regurgitation episodes. You have to define it for them, and you have to clarify what is the difference between regurgitation and vomiting, or you can tell them to send you a video of what the kitten or the cat is actually presenting as a clinical sign. Dysphagia, especially in the first stages of esophagitis, we might have odynophagia, which means that we have a lot of pain during swallowing, extension of the neck. A cat, I've also told in a lot of webinars that a cat that's protruding like this, extending the neck and doing ptyalism all the time, is is highly suspicious of esophagitis and triaditis as well, but of a gastrointestinal problem, of a gastrointestinal disease. Okay. So in the beginning, the liquid meals or the canned meals are tolerated better than the solid dry food meals. But in the end, as the disease progresses and the stricture becomes even smaller, then sometimes they cannot even tolerate water. And of course, sometimes we might have some of these animals are presented with aspiration pneumonia and fever, because they have this dilation of esophagus just proximal, just cranially to the stricture. And most of these patients are force-fed by their owners because in the beginning, they have a ravenous appetite, but then as the disease progresses and they have severe esophagitis and they become, they do not eat anything, they become anorexic, and especially if they develop fever. And of course, we have, in the more chronic cases, we have weight loss and malnutrition. So please, in your differentials, when we see the causes, always put this as a possible differential in order to manage it in the beginning, in the early steps of the disease. Okay, let's watch this one. This is a kitten that was admitted to my practice. And this is my voice. I'm sorry, this is my assistant. And this owner kept telling me that this cat is vomiting. This small kitten is vomiting. And I didn't believe that it was vomiting. So I said, okay, let's feed the cat and see what's going on. You see that this small kitten has a ravenous appetite, is really, really hungry. I mean, it could eat actually our hands and the bowl by itself. So this cat, this small kitten had upper respiratory tract disease, and it was administered doxycycline for 2 weeks. This is the common, the most common in kittens. When you see kittens that have strictures, it's either congenital, which is rare in feline patients, or they have been treated with some kind of an antibiotic on a dry swallow. So this has happened, but the general practitioner, the first opinion, the referring vet, and the owner could not connect these two incidents. The fact that it took for 2 weeks antibiotic, and the fact that this cat had these regurgitating episodes. Okay, and let's see now, just 5 minutes after, not even 5 minutes, I mean, the minute we stopped feeding, the kitten started having nausea. And it's very, very, it's presented in feline patients with a clinical manifestation of vocalizing, of hopping all around and jumping all around, like as if they have seizures, with hypersalivation, and as if they have something like a foreign body in their mouth and they cannot stand it. So it's the clinical manifestation of that is very, very extreme and prominent. And you see that this poor cat is hypersalivating. And of course, it expelled all the content of the canned food passively and with foamy material around it. And this is where it gets dangerous for aspiration pneumonia as well, because you saw this cat and the symptoms. And of course, they're going to eat it again. This is very, very characteristic in these patients. They're going to eat it because the content has not undergone all the procedures of the gastric fluids of the stomach. So it's still food. And I have to remind you that these cats are really, really hungry because they're not being fed properly. The food does not reach the stomach. And we have the same case here with this one, this little fellow here. I'm so sorry when I see these patients, they're so small, so tiny, and they're suffering. And you saw how it expelled passively the food and it starts consuming it again. I'm sorry for those who will have dinner in a while. Hope it's not that disgusting for you, but we're vets after all. So, causes of esophageal strictures. We have 2 big categories. Okay, the intraluminal causes of the stricturing and the extraluminal. We're going to talk about that later. So, the intraluminal strictures could be caused by gastroesophageal reflux disease during general anesthesia, and especially if we have intra-abdominal manipulations and surgical procedures, because this enhances the chance of having gastroesophageal reflux and severe esophagitis. And as a consequence of esophagitis, then we have the stricturing. So beware of your cats that undergo general anesthesia, even for procedures that do not have to do with abdominal manipulations. For example, if you want to clean an abscess in a cat, it has been, we had cases that developed a stricture right after any anesthetic episode. But of course, the incidence is higher in intra-abdominal manipulation operations. Prolonged vomiting or gastric content that can cause esophagitis as well. Drug, caustic substances, chemical irritants that can induce esophagitis as well. And we're going to talk about this specific category of drug-induced stricturing. Esophageal foreign bodies, and of course, neoplastic. The first three are benign strictures, and we have the neoplastic stricturing in the end, that's intraluminal. Where do they present? Where do we have the strictures? So the strictures are where physiologically the esophagus is getting a bit narrower, and that's in the thoracic inlet, 5 to 10% centimeters cranial to the lower esophageal sphincter, and also the base of the heart, and just cranial to the lower esophageal sphincter. So these are the three actually spots that the three sites that the esophagus anatomically normally has a smaller diameter. Okay, and these actually are where the sites of the foreign body, where the foreign bodies are lodged. So it's only natural that these will be the sites of the stricturing as well. And we're going to take each cause step by step, and we're going to see some cases for each cause. So in a series, we have a lot of studies in the gastroesophageal reflux disease, especially in cats undergoing general anesthesia. And we had a series of 7 cats with benign esophageal strictures, and they had undergone nurturing ovary hysterectomy in 5 of those cases. So you see that it's not only in the intra-abdominal operations, because that's the perception. And of course, we had decreased lower esophageal sphincter tone as a result of the anesthetic agents that were used throughout the operation, and direct acid injury to the esophageal mucosa. So it has been proven that predisposing factors are head down position during the operation and intra-abdominal surgical manipulations. A lot of people ask me that what if I give, for example, PPI inhibitors before the nurturing or in the anesthesia? It has not been proven that it helps a lot for the reflux disease, but you can give it, and we now know that especially omeprazole and or the PPI inhibitors can alter the intestinal microbiota. So we are a bit more cautious by giving and prescribing long-term the PPI inhibitors. But once you see that after an operation, 2 or 3 days, the cat starts salivating or starts ptyalism, because this is how it starts, then you can prescribe them. Okay. And in one study, they have, if Yannis Savas from the university were here, he hates laryngeal masks, so do I. And the use of laryngeal, I know that many of you use laryngeal masks in cats, but unfortunately, we have more of gastroesophageal reflux disease with these masks rather than the ET tube. Okay, the endotracheal intubation. So in one study, the use of laryngeal mask airway devices in 40 cats resulted in 50% gastroesophageal reflux disease, compared to 22% of the cases with ET tubes. You see that even with the ET tubes, we cannot avoid having gastroesophageal reflux disease, so it depends upon your induction, upon your the maintenance of your anesthesia. And I wish that at some point we will have an anesthesiology to have an interactive talk in these cases. So clinical signs appear up to 20 days after the anesthetic episode. So don't be, if you have done an intervention, a surgical intervention to any cats, to any cat, to any feline patient, and even a month later, they come saying that this cat is regurgitating or vomiting because they don't know what regurgitation is, always connect it to your prior anesthetic and surgical procedure. And most of the owners will see signs during the first 10 days, but they will not be that prominent. Okay, it will be like sporadic vomiting, they will say, which is sporadic regurgitation, maybe ptyalism, hypersalivation, and these will be the primary signs. So the endoscopic findings of esophagitis: increased hyperemia and the vascularity is more prominent in these cases in cats, discoloration of the mucosal layer, friability, which is, in the esophagus is a bit difficult to assess how friable it is, because this can only be assessed once we're taking biopsies. And it's a very difficult organ to take biopsies from. We can have hemorrhages, we can have ulceration, we can have superficial erosions throughout the length of the esophagus, or if we have GERD disease, it will be confined in the area proximal to the lower esophageal sphincter. And of course, we can have secondary functional megaesophagus, because when we have esophagitis, this causes esophageal dysmotility disorder and the presence of pseudomembranes covering the mucosa. And I have a case to show you, an endoscopic case. And as I told you, most of the cases of gastroesophageal reflux disease is located cranially to the gastroesophageal junction. Yet, having said that, we have a lot of cases that have intractable vomitings and that have such a prominent gastroesophageal reflux disease that the gastric acids go up to the length, throughout the length of the esophagus and reach up to the pharyngeal sphincter. So it depends on the amount of the gastroesophageal content of the gastric content that's reflexed in the esophagus, and on the underlying pathology. Okay. And as I told you before, please beware of the Z line. This is the line of the stomach. This is actually, this is a normal border between the esophagus and the stomach, and it is not a lesion. This is where the mucosa, the esophageal mucosa, transitions to the gastric mucosa. If you have any questions, please post them in the Q&As. I don't mind answering questions, in order to have an interactive session. If you have any questions on what we're commenting, please pose the questions and we will answer them. So there are two grading systems. Actually, there are more in humans, but the most commonly used ones, the most frequently used ones, are the new Savary-Miller endoscopic grading system. This is the one I use, and it goes like: grade 1, we have one single erosion or exudate in one fold only. In grade 2, we have multiple non-circular erosions. In grade 3, we have circular erosions throughout the circumference of the esophagus. Grade 4, we have ulcers, we have bigger, not only superficial erosions, but deeper ulcers in the esophagus. And grade 5, we have Barrett's esophagus, which is, gastric metaplasia of the esophagus. And do we have it in cats? Yes, we do. We have found Barrett's esophagus. It's rare, but we have found Barrett's esophagus in cats as well. In humans, Barrett's esophagus is a very huge deal because it's a precancerous state, actually, of the esophagus. And there's also the Los Angeles classification system for esophagitis, grading from A to D, going from the lesions that you have maybe one or more mucosal breaks no longer than 5 millimeters, and not breaching the tops of the mucosal folds, as you see here. So there are different systems, but we most commonly use the Savary-Miller classification. Let's see this esophagitis in a cat. You see that due to the esophagitis, the esophagus has lost their rings, its rings, and also it has lost the vascularity. We cannot see the vessels due to the thickening and the inflammation. So this is a Persian cat, 3 years old, and it has gastroesophageal reflux disease due to a prior anesthetic episode. And what I'm doing now is that I just saw, while inspecting the esophagus, that you see here that a band started forming just proximally to the cranially to the lower esophageal sphincter. And this would be the place that if I scoped this cat 1 week later or 10 days later, it would have a stricture. So I go with a big diameter of an endoscopic equipment of my scope, and I go up and down in order to just destroy this band that just started forming. And of course, we will have to see that again. We will have to re-examine this cat in the later stages. You see that the esophagitis lesions, like the ulcerations, are going up to the thoracic inlet, to the base of the heart. And of course, this is, as I told you, after an anesthetic episode. This is now, you see here is the ring that's going to be developed. So we caught it in very, very early stages, because 1 week after the anesthetic episode, where the cat had hyalism, had odinophagia, it just came to the clinic. And of course, we combined the operation with the symptoms, and we said, okay, let's go in and see if a stricture is being formed. And we caught it very, very early. So the question of the referring vet was, you say that we have esophagitis due to an anesthetic episode. Are we going to sedate this cat again? Isn't there a danger, into developing a more severe esophagitis due to gastroesophageal reflux disease? Of course, there will be more reflux at this point, but it's more crucial to determine what's going on, if a stricture is already being formed, as I saw it now in the beginning, so that we can go more aggressively and treat it and manage it, so that we will not proceed into balloon dilations later. Okay, because you will see that the esophagitis can be healed in 2 or 3 days' time. The esophagus has an amazing ability to heal these ulcers that you're seeing there as esophagitis. So yes, there is an anesthetic, the risk of having more reflux disease, but there's always, you have to balance it and have your diagnosis. And I also detected the beginning of the band of the stricture there, and I dilated with the tip of my scope. Okay. And in terms of Barrett esophagus, the development of metaplastic columnar epithelium that replaces the normal squamous epithelium. Okay. We have 3 cats reported to have Barrett-like esophagus, in which 2 of them have had hiatal hernia and 1 had cardiac failure. And of course, it's the most commonly reported cause of Barrett esophagus in humans are the gastroesophageal reflux disease, and in humans it's mostly there's always almost always a hiatal herniation. Okay, and the true incidence in cats we do not know, because we do not biopsy actually the esophagus. And we had this Persian cat, 8 years old, with lymphoma and chronic gastroesophageal reflux disease with Barrett esophagus. You see the lesions here, and you see the metaplasia. You see this is gastric epithelium, actually, in the metaplastic epithelium, to say it even better, in the esophagus. And this is a hyperthyroid cat with chronic vomiting and Barrett disease as well. And most, of course, of the lesions are, not most, all of the lesions are at the gastroesophageal junction. Let's go to another one, and I really, really want you to be cautious about that one. I know that most of that there is a lot of awareness nowadays about giving antibiotics in general, and primarily about giving antibiotics in cats on a dry swallow. And we used to think that it was about doxycycline, for example, or clindamycin, for example, because for these two antibiotics, we had a lot of research going on, and also a lot of cases, a series of cases report that were actually giving evidence about what clindamycin and doxycycline could actually do to the esophageal mucosa. But it actually is, this is not, so simple. Every peel in the cat, every peel that you will use in the cat, even the antiparasitic pills that you give for deworming in your practices, they should be followed by water. And it has been actually calculated, the amount of water for to give to a feline patient in order to swallow a pill is around 7 ml of a water in a syringe. Or if you don't want to risk your life with a cat giving, water in a syringe, just give a small amount of food. Okay, so it's very well, pill-induced esophagitis is very, very, is well documented in humans. It's an entity that has been researched a lot. With over 70 drugs, when I went across the literature, to find out what's going on in humans, there was a huge list of 70, 80 drugs that can cause drug-induced stricturing, benign stricturing in humans, esophagitis. And as I say here, that stricturing is very rare in humans, but very common in cats. And antimicrobials and non-steroidals are implicated in 50% of the published cases, okay, in humans. What about the benign esophageal stricturing in cats? So we know about oxytetracycline, about doxycycline, about clindamycin. We have research papers about that, but this is not evidence-based. We know their result when we give them, but it's not evidence-based, and always on a dry swallow. This happens when we give pills on a dry swallow. So what could be the underlying mechanism? Maybe prolonged contact of the esophageal mucosa to a drug and its direct chemical effect. And because we have seen, for example, that parenteral administration or subcutaneous injections of amoxicillin or parenteral administration of these drugs do not cause esophageal, do not have the same results. So it has to do with a topical effect in the esophageal lumen. And the esophagus, the esophageal mucosa, has a lot of protective mechanisms to drugs, like the esophageal mucus bicarbonates, the multiple layers of the esophageal epitheliums, the strong cell-to-cell connections, the intracellular lipids. So there are a lot of protective mechanisms to undergo for these drugs to actually cause erosive ulceration, erosive lesions and ulcerations in the esophagus. In terms of doxycycline, it has been proven that it creates an acidic solution in the neutral esophageal pH. So this is corrosive, and this ulcer-forming effect has been experimentally documented, and also we see it in our everyday life. But of course, in science, it's a different procedure, to evidence-based, to base under evidence all of these data. And we have doxycycline accumulation in the basal membrane of the esophageal squamous epithelium. So in terms of doxycycline effect, it has an acidic effect on an ulcer-forming effect on the esophageal mucosa. And let's see this one here. This is Oscar, a 2-year-old male cat, and you can see these pseudomembranes here. And this is very, very high up in the pharyngeal, just after, it was like 1 centimeter after the pharyngeal sphincter. So the peel, this cat was treated with doxycycline for respiratory tract disease, and for upper respiratory disease, nasal discharge, and this combination of diseases, ocular discharge. So they gave him blindly doxycycline. And a week after the administration of doxycycline, it started having odynophagia, very painful swallowing. The cat was vocalizing, and it was, like it was really in pain. And most probably the pills have been stuck here in the pharyngeal region, and they have caused, by a chemical effect, they have caused these pseudomembranes, necrosis of the esophageal area. So in the upcoming, and of course this cat had pharyngeal regurgitation. The stricture is not that prominent here, but if we left it, for example, of course there is a stricturing of the esophagus, but not that prominent as the strictures that we see already formed with a band, because this is in the beginning. These are at the stage of pseudomembranes. And this, if we just left it like that, and let's say, for example, that the owner or the veterinarian prescribed only food, canned food, this cat would be able to actually swallow canned food, and it would proceed. This procedure would go on, progress, and it would form a very firm stricture. Okay. And of course, with the tip of the scope, you can just destroy all these lesions. We took some biopsies as well in order to verify that this was necrotic tissue and not something else. And this is another cat, Sheba. This cat is 3 months old, got doxycycline as well for upper respiratory tract infections. And you see, this is very, very in the very beginning of the stricturing. We have pseudomembranes again, okay, and the stricture has already been formed, but it's very easy to manipulate without balloon. Only with the tip of the scope, you go up and down, up and down. And if you have a colonoscope, if you have a bigger scope, bigger diameter scope, and not just one scope, because this was a small kitten, we used the bronchoscope. And then I went with the 8mm scope and opened it a bit wider so that it can stay. And of course, these patients have to be re-examined in 3 or 4 days, because the stricture will be reformed. We know that for sure. And of course, they should be given a very, very aggressive treatment for esophagitis in order to avoid this restricturing. And clindamycin does not alter the pH, has a totally different mechanism and causes minimal mucosal irritation. So the etiopathogenesis of how the benign strictures are formed from clindamycin is the increased transit time through the esophageal lumen and the increased duration of contact with the esophageal mucosa, which means that clindamycin has a more mechanical effect. And this happens with a lot of other peels. We have, I will show you one of my papers published that we had the same effect with amoxicillin and clavulanic acid, which is not clindamycin. It's due to the mechanical effect and the fact that peels, I will show you what the transit time of peels is in cats, take so long. I mean, more than 3 hours sometimes if we just give them on a dry swallow, to proceed from the esophagus into the stomach. So they remain embedded like foreign bodies in the esophagus, and this is how they cause the esophagitis. So we have the dry swallow, we have the esophageal hypomotility, maybe if the cat is a bit dehydrated, maybe if we have another systemic disorder. And also there is the formulation that plays a great role, like the capsules, for example, or is it in tab form? Is it in capsule form? This plays, is it in, because the same drug in syrup form will never cause a stricturing because it's not out of the alteration of the pH, as we said, it's more of the mechanical effect. And giving in cats human drugs that you cut in half because they are, for example, cheaper. In terms of doxycycline, for example, we have this drug that's called vibramycin, and it's a human drug. And when you cut it, you can give it to cats as well. But the thing is that once you cut it, this pill has a cover. You destroy the cover, first of all. And the second thing is that once you cut it, then it becomes very, very sharp. And this actually can cause mechanical irritation to the esophagus out of being embedded there. And this is the article that we have actually peer review article that we have published. And it was with, we had 3 cases, we presented 3 cases, one with clindamycin, one with doxycycline, and one with amoxicillin and clavulanic acid. In humans, it is one of the implicated drugs as well. And the mechanism is similar to that of clindamycin, as we said, because they cause mechanical problem due to the transit times. And this was our cat. We had megaesophagus cranially to the strictures, to the stricturing, and you see how small the stricture was. I couldn't even pass a urine catheter, a dog urine catheter from this stricturing. Okay. Dry solo of capsules or tablets in cats can result in retention of the drug. This is what I want you to remember. For a duration of 30 to 240 seconds. So it's a long time. It's a really, really long time. And in a different study, more than 50% of capsules administered to healthy cats were trapped in the cranial thoracic esophagus. So this is why I mentioned your antiparasitic pills. Okay. A competitive study demonstrated that if we want to give the pills, then we could at least give them with one-step pill gun with flavored liquid, or with these pockets, with these pill pockets, so they can transit and they can travel through the esophagus easier. So this will ensure less than 60 seconds. And of course, the trick with the water, as I told you. And we can have a benign stricturing due to esophageal foreign body. And of course, in cats, esophageal foreign bodies are less commonly found in the esophagus compared to other sites of the gastrointestinal tract. What are the foreign bodies that we commonly see in cats? Strings, needles, fish hooks, bones, trichobezoars. Don't forget about it. If a trichobezoar is really, really firm and hard, then it can act as a simulation of a foreign body. They can be lodged anywhere in the esophagus. Okay. And of course, the common locations, again, are the thoracic inlet, the heart base, the esophageal hiatus in the diaphragm, which is cranially to the lower esophageal sphincter. And chronic esophageal foreign bodies have been reported with intermittent regurgitation of, for example, trichobezoars. Okay, and they cause esophagitis and then stricturing. Always look underneath the tongue. This is a trichobezoar that has been embedded in the esophagus, and these are the linear foreign bodies, okay, that can cause gastroesophageal reflux disease. Of course, they cannot cause intraluminal obstruction of the esophagus, these linear foreign bodies, but they can cause intractable vomiting. And this is how the stricturing comes. Always sedate the cats with ptyalism and hypersalivation in order to see what's going on underneath the tongue. And this is a 10 years old male cat that actually had a string, as you can see here, going from the esophagus to the stomach to the small intestine. And do not push these strings, because the string might be, the other edge of the string might be in the small intestine. So this is why these patients need endoscopy. And here is the pyloric region, the incisura angularis, and you see how the string, how much the pressure of the string is, that it cuts into, you see the string here, it cuts into the incisura angularis. Okay. So you do not, and we are not pulling the string at all. We're not pulling this string. This string has proceeded, as you saw, in the intestine. Okay, now you will see it in the esophagus as well, remaining in the esophagus. And this cat had ptyalism, hypersalivation. Of course, the string was underneath the tongue and it could not apprehend the food. Very painful, not only swallowing, but eating, regurgitation. And we would reach up to a point where, when we had severe esophagitis, it would form a stricture. And when these patients are admitted to us, we have the fibrous ring that already formed, that reduces the diameter of esophageal lumen. Very few cases have active esophagitis. Most of the cases, actually, that need balloon dilation and that need to undergo this procedure of dilating the stricture come with an already formed esophageal stricture. We can have or not esophageal lesions. We can have or not dilation of the esophageal lumen cranially to the site of the stenosis. And the mucosa is only irregular when it's neoplastic. In every other case of stricturing, of benign strictures, the mucosa is, a glistening fibrous connective tissue. And in terms of neoplastic disease, squamous cell carcinoma is the most common primary esophageal tumor in cats. In the caudal 2/3 of the esophageal lumen, I'm going to show you a video of that. Of course, older cats, middle-aged to older cats, mucosal biopsies you may try. It's a bit difficult to obtain. Brush cytology in these cases may be diagnostic. We managed, though, to take biopsies from the patient that I will show you. Poor response to chemo or radiation. And what we can do in every neoplastic intraluminal procedure is palliative esophageal stenting. Of course, they can migrate. The stents may migrate. And of course, you're going to have proliferative tissue covering the stent at some point, and the neoplastic stricture will be reformed, but you give time to the owners to realize the procedure, and you also give time to your patient. Your alternative will be to put a PEG tube, and feed through the PEG tube, because these patients have weight loss and are really stunted. And let's see this 13-year-old male cat that had regurgitations and stricturing, and you see the proliferation of the neoplastic tissue. And to be honest, this cat had nothing else. CBC, biochemicals, his demeanor, his general demeanor was so, was normal. And it was such a pity. And you can put a palliative stent. This is what I suggested, but financially they could not afford it. This is what we would do in this patient up until, the proliferation would even obstruct the stent. We took biopsies, of course, and it was easy because it's very friable from this patient. Chronic vomiting. Any disease that might cause chronic vomiting to our patients might be implicated in stricturing, like the two big categories, the gastrointestinal diseases and the extraintestinal diseases like hiatal hernias, endocrinopathies like hyperthyroidism, and also diabetes ketoacidosis, for example, that causes intractable vomitings. IBD or chronic infiltrative diseases that can cause chronic vomiting as well. Megaesophagus cases that cause, that because the food is retained in the esophagus and it causes esophagitis. Dysautonomia in cats and triaditis, other metabolic disorders like kidney failure, for example, chronic kidney disease. All of these diseases can be implicated in esophagitis and at the later stage on stricturing. Always be aware of that. And also some hyperthyroid cats will be admitted to your clinic, not with vomiting, but with regurgitating episodes due to esophageal hypomotility as well. It doesn't have to be a stricture, but hyperthyroidism does not only cause vomiting, chronic vomiting, it can cause due to esophageal hypomotility, it can cause regurgitation episodes as well. And of course, we have the extraluminal causes, which are vascular ring anomalies, and the most common is the persistent right aortic arc, where the esophagus is entrapped by the aorta, the ligamentum arteriosum, and the pulmonary trunk, the heart base ventrally. You see here that we have a megaesophagus just priorly to this entrapment of the esophagus, and in some cases of lymphoma and thymoma. And this is how it looks. So when you go into scoping, and we have a very nice case of a late onset of persistent right aortic arc in a dog. If you go into our YouTube channel, Aohua YouTube channel, you are going to see this case. Because we were thinking that it's only in very young animals, and that's the most frequent admission, but we can also have late onset of these diseases of diagnosing a persistent right aortic arc in dogs especially. Okay, so most of the cases, the onset of signs, of clinical signs, is in animals less than 6 months of age and shortly after weaning, and during their transition to the solid food. So in these patients, we have regurgitation, they're underweight, and they could be presented with aspiration pneumonia due to the megaesophagus, as you see here in the X-ray. That's cranially to the entrapment of the esophagus. We can have survey radiographs, we can have contrast medium radiographs, and what they show is this dilation of the esophagus cranial to the heart. So when you see that you have this kind of stricturing at this site, it could lead to this congenital anomaly. And of course, it's surgical. The management is surgical, and there is a double aortic arc there has been published a double aortic arc in a Siamese cat. So yes, this disease also stands for cats. So in general, what do we do for the diagnosis of a stricture? Lateral radiographs always, even if they're rarely reveal the stricture site, especially when you have multiple, but you do them because you might get suspicious of a dilation of the esophagus, for example, or to inspect the aspiration pneumonia if it exists, for example. Most of the times we do contrast medium radiographs, so we see the esophageal dilation proximal to the stricture site. And of course, endoscopy is the gold standard for strictures. you will detect if there is an active esophagitis or not. And as we said, that the strictures appear as a ring of white fibrous tissue when they have already been formed. In the beginning, we could see pseudomembranes. We could see this beginning of the fold of the esophagus that's starting to actually reducing the diameter of the esophageal lumen. And of course, with fluoroscopy, and we do everything as a pre-op before, just priorly to go into the endoscopic room, because you want to know the underlying disease. So you definitely do, or the cause of chronic vomiting, or the cause of gastroesophageal reflux disease, or if there is any other underlying implicating agent in the forming of the stricture, because even if you dilate the stricture and the pathology remains, then you will only have done nothing. This will recur. So CBC, biochemical profile, electrolytes, urinalysis, T4, blood pressures. Okay. And let's go to the favorite part, which is the treatment. We can use the boogies. I've never used the boogies. Balloon dilation catheters, the distal tip of the endoscope, especially when it started forming, okay, or in your repetition sessions after the first dilation with balloons, you can use the tip of your scope. And of course, nitinol stents, biodegradable self-expanding stents. We used to think that we should repeat the procedure, the sessions, whenever the cat starts regurgitating again, which is wrong, because this means that the stricture will have already been formed again. So we repeat the procedure every 4 days to 1 week intervals. I usually do it every 4 days maximum. And the maximum number of dilations are in the literature, are between 8 to 11. And then even in humans, they put stents. But it has been, for me, for example, I have done in small kittens. In this black kitten that you saw in the beginning, we've done 14 procedures. It depends on the owner's financials and also the response. And now it's, it's treated, it's a young adult cat, and has no regurgitations at all. But it took 14 of these procedures. Now, the boogies, I don't use them. I have used them, just to see how they work, but I don't actually like their application. I don't know if any of you use boogies. Please feel free to chat in the Q&A. They're narrow, long. They are dilators, and they're available in different sizes. And what you do is that you go with a smaller size, and you gradually increase the size of the boogie that you use. In cats, from 9 to 12 millimeters. It's proceeded gently through the narrowing over a guide wire, of course, and always under a visualization, endoscopic visualization. And the initial size of the boogie is approximately at the same size of the stricture, because they do not have the same mechanical effect like the balloons. So we have to be very cautious with the boogies. The mean stricture diameter has to be 5 millimeters in order to use the boogies, and the length less than 1 centimeter. And sometimes we have bigger strictures. We have bigger in length, longer strictures. Sometimes the strictures could be up to 3 centimeters, 5 centimeters long. It depends on the cause of the esophagitis and the severity of the esophagitis. And in one retrospective case series of 8 cats treated with boogies, the median number of procedures were 4.5, so around 4 to 5 procedures, and it was successful in about 75% of the cases. So it's actually what you're more familiar with. But there has not been, in veterinary literature, the boogies have not been used long enough and in a lot of cases so that we can have safe results and safe and can safely advise it. Okay. So boogies versus balloons, which one is safer? This is always the debate. No data in cats. There's no difference in literature between boogies and balloon dilations of benign esophageal strictures regarding symptomatic relief, recurrence rate at 12 months, bleeding and perforations. So the only thing is that patients that undergo balloon dilation experience less severe post-procedure pain. That was the only difference. Actually in humans, but we have no data in cats. And it's a bit different, the perception of pain and also the procedure per se, because the esophagus of the cat is totally different from the esophagus of the human. So we do not know. And what we mostly use are the mechanical dilation balloon catheters. This is my method of choice because the forces that are actually developed are radially directed rather than sharing axial forces, okay, in the mucosa. And this minimizes the risk of rupturing the esophagus. The balloon can be placed through your working channel. It can be placed alongside your working channel with visualization. And this is what I do. I never put it in my working channel because I might want to do other things. I want my working channel to be free. And also sometimes we put some KY gel in the balloon. So I don't want to put this KY gel through my scope because it will ruin my image. So most of the times I just put it alongside the endoscope. This is a bit more hard to manipulate it and find the center of the stricture. But once you get the grip of it, it's you have your scope, you know, and you can put other forceps, for example, or whatever else you know you might need in your scope. So it's easier for me to do it alongside the scope. And of course, there's a variety of balloon sizes. It depends on the size of the patient, dog or a cat. And I mostly use the triple expansion because it gives me the opportunity, once I dilate the lumen, to dilate it the second time, you know, a bit more, and dilate it a bit more the third time. So the triple expansion has, for example, 10, 12, and 14 centimeters. So in the first scale, you can open it up to 10 centimeters, and then 10 millimeters, sorry, and then 12, and then 14. Okay. So in one study, the size, how do I select the size of the balloon? The inflated diameter was 4 millimeters longer than the stricture diameter. Okay, 4 millimeters bigger than the stricture diameter. So these are my case series. This is how we did. You see here that this first cat had no lumen. The stricture had actually no lumen at all. And this is the tip of the balloon, the guide wire. Okay, only the guide wire was actually proceeded through the whole of the stricture, the diameter of the stricture. And then the balloon is preceded, and then the balloon is inflated. Okay. Inhalation anesthesia, left lateral recumbency. Okay. Flexible size of your scope, 7.5, 8.5. Do not use your bronchoscopes in dilating in the balloon dilation procedure. Use your scope, because then you might go up and down after the dilation with a bigger diameter scope. And in cats, we use from 8 to 20 millimeters diameters. What if I only have money to buy one balloon? Buy the 20 millimeters one. You will not be able to do the small kittens, but you will do every average cat. Okay, And you can also use it in small small breed dogs as well. So the 20 millimeters diameter is something that you must have. And 8 to 10 centimeters length balloon catheters we always use. Sometimes 5 to 10 centimeters, but if you have an 8 to 10, then you can use it to most of the strictures. Most of the cats after the procedure are able to eat the very same day, and they're very hungry, even though they're very, very painful. Okay, because we have caused such a trauma to the esophagus that's very painful, but I will tell you how to minimize it. Please do not use the ET tubes to dilate a stricture, because this is how the esophagus is ruptured most of the times, okay? The ET tubes do not substitute the balloon catheters. And potential complications, which I only had once, in a cat that had atresia, which means that there was no entrance of a stricture. There was actually, it was a closed tissue. We had no tissue, okay? So you can cause esophageal rupture, pneumothorax, pneumomediastinum, mild tissue injury, and esophageal wall bleeding, which is expected. The last ones, not mild, severe esophageal tissue injury we have, and also we can have a lot of bleeding, you will see. The procedure, what is the total number of dilations? It will depend on the initial size of the stricture, on the aggressiveness, how experienced are we as endoscopists? The more experienced and the more aggressive you are, but of course you have to balance it, your aggressiveness with, the gradual progress of the of your procedure. Okay. The tissue response of the affected animal. Some patients are really reforming the strictures in 2-3 days time. The chronicity of the stricture, have we detected it in very early stages, or is it, has it been there for 2 or 3 months that the cat has been regurgitating? The average sessions are from 4 to 6, but as I told you, in many cases, we have done more than 14 procedures, and a higher number of sessions than what is reported in the literature as maximum should be considered if you don't have an alternative, like a stent, for example. What do we do after the procedure? After the procedure, we can do topical injection with a sclerotherapy, an injection needle at the dilated stricture of triamcinolone, okay, in 4 quadrants of the esophagus, and we make 4 to 6 milligram per cat, and it's in 0.5 ml aliquots. I will show you how it's done. And intralesional application of mitomycin C serves the same purpose. What is the prognosis? 10 to 30% of the cats are euthanized despite multiple dilations. I actually have a bigger success rate in these animals because we persuade the owners to go through the procedures, multiple procedures, and every 3 to 4 days. And up to 33% of the cases can only be fed liquid diets, which is, acceptable. What is the medical treatment after you dilate the stricture? PPI inhibitors in order to reduce the gastric acid secretion and not to have more gastroesophageal reflex lesions. Sucralfate, always use it in suspension form, not in tablets, okay, to protect the ulcerated mucosa. Cisapride, I always give cisapride after this procedure because there's already an established esophageal motility, and we want to increase the lower esophageal sphincter tone and enhance this, not only the gastric emptying, but also enhance the esophageal motility. Broad spectrum antibiotics. The use of systemic corticosteroids, because I know that a lot of you use prednisolone in these cases, is a bit controversial. I don't use prednisolone. And sometimes in order to achieve analgesia, because I want these cats to eat as soon as possible, I put 2% lidocaine gel that's diluted with 10 mLs of normal saline in a syringe, and I put it throughout the length of the esophagus under endoscopic guidance. And of course, there's always the choice of esophageal stent placement. The biodegradable polydiaxon self-expanding stents are the ones that I choose most of the times, but unfortunately they tend to migrate. So it needs a bit of more expertise in order to choose the correct standing and the correct length of the stent. And also you have to have equipment like a C-arm, for example, in your clinic. And let's see a case now. As well. Let's see this one, and we will go through the whole procedure. The domestic short hair. Hi, Ismail. We're going to talk later about that, and you can have your input in that as well. So we have a domestic short hair male intact, so it didn't undergo any procedure, this cat, anesthetic episode or anything. 9 months old. Okay. The clinical history. So this cat, which is called babies in Greek, was sneezing, and it had bilateral copious amount of mucous nasal discharge 1 month prior admission. It also had serious ocular discharge and blepharospasm. There was a presumptuous diagnosis of upper respiratory disease, but it was not confirmed, with PCR if it was herpes virus, calicivirus. None of these preliminary tests were done, and it was prescribed doxycycline for 2 weeks at 10 milligrams per kilo per os with resolution of respiratory signs. Everything went well in terms of his upper respiratory syndrome. The ocular discharge, the nasal discharge was reduced, and no more sneezing. Absence of oral ulcers in the physical examination. Okay. Ravenous appetite in the beginning, but progressively after 2 weeks after the doxycycline administration, we had gradual loss of appetite, hypersalivation, and ptyalism. And 2 weeks after cessation of doxycycline, we started having regurgitation episodes. And it was 2 weeks after the cessation. You see that it took some time. It took 2 weeks in order for this cat to start regurgitating, with an increasing frequency, first on solid foods and then on water. And of course, weight loss. Let's see what it does. This is how it started. So this cat started having episodes of hypersalivation, and just right after consuming the meal. And this strange behavior that something is wrong, but no vomitings in the beginning, huh? I'm certain that you all have videos like that. The cat is just staring at the owner that's taking the video right now. And they will start pawing at the mouth. He will start pawing at the mouth as something is wrong. Sometimes the owners might lose the regurgitating episode because the cat has the regurgitation and it goes right up and reconsumes the food. So in the beginning, there were no regurgitating episodes. This was the first video that the owner has sent to the clinician, to the referring clinician. Okay, and let's see how it progressed over 1 week time. The cat has lost more weight, dehydrated even more. And you see that the ptyalism and has become a bit more severe. But now, in the end of all these episodes, we do have regurgitations. Okay, and it was very, very passive. You will see that it comes passively. So it's just an extension of the neck, and it has been given dry food, as you see here. So this was the beginning, that it could not tolerate the dry food. So after that, they would give, canned food, and even that, they could not tolerate the canned food either. And the period now, as it progresses, is even shorter. So it took some time in the beginning for the cat to regurgitate, but now it's becoming, shorter, the interval between the meal and the regurgitation. It's expelled very, very easily. Physical examination findings, as I have already told you, always use the muscle condition score and the body condition score in order to evaluate your patients. And we had a mild dehydration, around 7%, body condition score 3 out of 9, muscle condition score B. The thyroid gland palpation was normal, and it was a very, very young animal, 9 months old, but we always do it as a part of our physical examination. Mucous membrane is normal, and a sinus tachycardia. So in every case that we have to create a problem list: regurgitation, the first problem, ptyalism, and anorexia. And the regurgitation in cats could be the idiopathic functional, could be due to idiopathic functional hypomotility and megaesophagus, primary functional dysmotility, like in the Siamese and in the Bengal cats, esophagitis, which causes secondary esophageal dysmotility, hypomotility, toxicity causing megaesophagus, like lead toxicity or botulism, congenital defects, as we said, that cause stricturing, like the vascular ring anomalies, type 1 sliding hiatal hernias, feline dysautonomia, myasthenia gravis with thymoma or not, especially in Abyssinian and Somali cat. Toxoplasmosis, for those of you who do not know that, can cause regurgitation out of dysmotility, esophageal dysmotility, foreign body, because of the embedded foreign body in the esophagus, hyperthyroidism, and benign esophageal stricture already formed. And the hematology results, you see that we have mild, subtle changes, not, something very, very prominent. Like, of course, we have a neutropenia, but it's not severe neutropenia. Mild lymphocytosis, which is, for cats, it's a bit normal to have lymphocytosis, and monocytosis, very mild. And I know these are Greek, but you can see the English ones because they were performed here in Greece. But you can see the English abbreviations here. So the creatinine, the albumins, total proteins, the transaminase, the phosphorus, calcium, potassium, sodium, and the BUN, all normal. Okay. And FIV and for leukemia virus tested negative. Urinalysis, specific gravity of 1050, it's normal for cats. And also, I have to remind you that the cat was a bit dehydrated, even though the urea was normal, you saw. Inactive sentiment and no proteinuria, the urine culture negative. And let's go to the imaging. So we took, in the beginning, a plain radiograph, and you can see here this in the rear lungs, in the rear thoracic fields, that there was something, we were questioning, is it a sliding hernia? Is it, something like a dilation of the esophagus there? Is it lung disease, pneumonopathy? And the abdomen was normal. And then we did the contrast medium, lateral with gastrographing. It was an esophagogram, actually. So there was a stricture formation right cranially to the lower esophageal sphincter, and that's esophagography at 5 minutes after consumption of the contrast medium. And this is 10 minutes after the contrast medium, and that's 20 minutes. So the stricture is here, but some contrast medium passes in the stomach. And of course, we did a CT scan, and it verified actually the mural thickening of the esophagus and the esophageal stricturing, and the thickening of the esophageal wall. And we did a total body CT scan, so we found out an hepatomegaly as well, and a bilateral unstructured interstitial pneumonopathy, which could be due to the upper respiratory syndrome that it had priorly, but it was like a bronchopneumonia, like asthma-like lesions. Okay. And let's see the stricture. So you see that there's a lot of saliva and foamy material. We have active esophagitis. The esophageal lumen is not glistening and normal. We have erosions, superficial erosions. And we will reach the stricture, which is proximal to the lower esophageal sphincter. And you see that we're going from a dilated esophagus to this kind of a stricture. How can I assess the length of the stricture? I can put a forceps through the working channel of my scope and open the jaws of the forceps in order to calculate, the diameter. Or I can put a Foley catheter, for example, or a urinary catheter in order to assess not only the length, the diameter of the stricture. So you see that we have a very well-formed stricture, and now you see this red out because I'm trying to see if I can pass through the stricture, which was not possible, of course. And we would need to do balloon dilations. That caused a trauma here. Please don't do that by yourselves. So what I should have done is go out and put a balloon catheter, which we did. So this is the first session, and you will see that we have caused, so we put the balloon in the middle of the stricture. We proceeded up until it reaches the middle of the length of the balloon. Okay, and then we start inflating, either with water or with air. With water, you have a better hydraulic effect, but with air, it's safer. I do it with water. I fill my balloon with water, but you have to dry it really well afterwards. Okay, and we keep it for at least 30 to 40 seconds, and up until we see that blood is coming out in the circumference of the stricturing. you have to understand that in this procedure, you will have to cause trauma, major trauma. So don't be afraid to cause it. Otherwise, your procedure will not be successful. So if I had to say one pitfall, one common mistake that people do in these procedures is that they're scared, so they do not dilate the balloon, or they choose a balloon diameter that's smaller than it should, so they do not cause big trauma to the esophagus. And we have restricturing, very easy restricturing after that. You see the bubbles and the blood that's coming out. Don't be scared. This is what you're supposed to do. Okay. And this is right after the first procedure. You see my urine catheter here. You see how big of a tearing we have caused to the esophagus, okay? And you see a urine catheter with my xylocaine infusion in order for the cats to be comfortable to eat right after the procedure. So I'm putting my xylocaine, you can see that here throughout the length of the esophagus. And then 3 days later, the second balloon dilation, because I don't wait for more days, you see the damage. It has reformed. It has reformed not to the initial small size that it was, but it was a big stricture as well. So this time I went in more aggressively, as you see, and into the stomach. This is blood coming from the esophagus that's digested, okay? So don't worry. It's not gastric ulcers. And now what I'm doing is I'm going up and down with my scope, and I put a bigger scope, a bigger diameter scope, up and down in the stricture, okay, in order to dilate it even more. But you see that this time I was a bit more aggressive, and I caused more trauma to the esophagus. Do I remove this tissue here? No, I don't. I do not remove this tissue with a forceps. I just leave it like that. And again, what you can do is some triamcinolone, but of course, this is a very, very lengthy stricture. So most of the times we do triamcinolone in quadrats when we have a stricture that's shorter. Okay, but of course you can do here circumferentially triamcinolone injections if you want. But this is a big tearing of the esophagus. And now it has a diameter that the cat can definitely eat and pass the food. Okay, let's see now. My residents were really, really scared when they saw, this distraction that we have caused. But this is what you're supposed to do, as I said. And I'm not just staying there looking. I'm going up and down now. Now I'm doing, actually, after the balloon dilation, I am multiplying my effect. Okay. And let's see now what happened 7 days after admission, which is 3 days after the second session. Let's see the third session, 3 days later now. You see the dates as well. Let's see what happened. This is pre-dilation, before dilating. This is the tracheal indentation. Let's see if it has reformed or not. And it has reformed, but to a lesser extent than the first times. You remember that it was, less than, not 1 centimeter. It was even smaller, the stricture, the initial stricture. So now we do have a lumen. You see that it's okay, maybe canned food or food that's been diluted with water can pass, but we're not happy. we still have to dilate it. Okay, again, the third session. And the stomach looks fine. And let's see the post-dilation. Let's see what we have post-dilation. You see blood coming. So this means that we have a very successful procedure. So we have tear up the whole length of the esophagus again. And of course, after every procedure, we give sulcrafate, we'll give an antibiotic. It would be great if most of them, you could do them injectional, for example, the antibiotics. And then in cats, they're so problematic. We will have the feline injectional site sarcomas with the injections. But anyway, in these cases, which I'm trying to do the antibiotics in injection form, the less peels they take from the mouth, the better it is. The sulcrafate in suspension, not in peel, because it doesn't have this coverage of the esophageal mucosa if you give it in peel form. Okay, so we cause again the trauma. And it took these 3 dilations, actually, this cat, in order to have a circumference that's good enough to have canned food, for example. The owners were happy with that, so that was great. Oops, sorry. And so we gave amoxicillin plus clavulanic acid, sulcrafate suspension at this dosage, cisapride in order to increase the motility, low-fat diet because it enhances the motility of the stomach, the gastric emptying, fed from hide. This is a new one, like the Bailey's chair in dogs. This is like, a device for cats that have megaesophagus or that we want them to eat from height, which is not absolutely necessary in these cases because they don't, they resume their capacity of esophageal motility, but in the beginning, it's very, very handy. And of course, triamcinolone aliquots in forms of injections during your endoscopic procedures. So this is pretty much everything. Powell, I see that you have your hand raised. If you want to ask something, please do. Another common mistake is that a lot of you put the balloon through the scope, and this gives you less visibility of your site and less capability of being less flexibility in manipulations. When you put it alongside, it needs a bit more proficiency in order to get it in the stricture, because a lot of people are laughing at me and they're saying, I mean, there's only one hole. Why the balloon cannot be inserted in there? Because the balloon is not, you have to have a guide wire and put it through on the guide wire if you want to be really, really targeted where to orient it. If you have any other questions, I'll be happy to answer. And even if you don't think about it now, you can always email me. You can always email me cases to discuss and share, knowledge and opinions. And please tell me if you prefer this time for the webinars or maybe during noon. Don't forget to say that, because we will proceed according to your answers. Ishmael, yes, I did have. The question is, have you ever had a case of perforation after this procedure? Of course I did. As I told you, I had a cat with atresia, total atresia. And we should perforate it. There was no alternative. And what do you do when you perforate? You have to have a surgeon handy, because you're in the thorax right now and creating pneumothorax. I had once in a cat and once in a puppy, in a very young puppy that had a foreign body for 2-3 weeks there. So, and also it's easier to have a perforation in neoplastic disorders because the tissue is not healthy, you know. The esophagus is an amazing organ, and it's very difficult to perforate. Very difficult. I've done many of these such procedures, and I only remember 2 or 3 perforations. So don't be afraid to do that. And if you don't want to have, you know, perforations in the beginning when you're doing your procedures, try it with a balloon of less diameter. Okay, you will not have the effect that you want, the therapeutic effect that you want, but you will definitely, you know, start to do the procedure. And once you feel safe, then you will you will be more aggressive, as I was. Thank you very much for attending, Anna, as well. So how long after the operation is allowed to feed and what? We feed, as you see here, the cat, we feed them as soon as they're waking up, you know, 2 or 3 hours after the operation. We're feeding them, we're starting off after it depends on which session we are. If we are after our first balloon dilation session, we start off with canned food. And most of the times, because the esophagus is ulcerated, we start with dilated canned food, as here, as you see the cat here. And then as we progress into the dilations, let's say the 4th session, we can try canned food without dilution. And then in the 5th session or 6th dilation, we can try dry food, but soaked dry food, and then the dry food. Okay, you will go gradually. And I mostly use low-fat foods, like the ID low-fat or the gastrointestinal low-fat of Royal Canin, the canned food. So I use low-fat diets. The gastrointestinal diet is an easily digestible diet, is very good. Special meatballs? What you mean, special meatballs? Special meatballs of what? Yes, for dogs, we can use canned food as well. We use canned food, low-fat diet, canned food. So they eat straight after the procedure. Straight after the procedure. Okay. Because these animals have lost weight, are malnourished, so we do not, and especially for cats, you know that there is a huge problem with hepatic lipidosis. Okay, so you don't want to have, and you saw that this cat had, the one that we saw in my case, had hepatomegaly. So you do not want to keep a cat unfed for more than 2 or 3 days, because you will encounter other other problems in the long run, like hepatic lipidosis, and then, you know, a vicious cycle will start of anorexia, vomiting, and restructuring. We want to keep them very, very well nourished. And always think about the refeeding syndrome. If your animal is anorectic for more than, you know, 3 or 4 days or 5 days, when you reinitiate food, please check your phosphorus levels and check your potassium levels, because the refeeding syndrome can cause severe hypophosphatemia and hypokalemia, and this could cause hemolysis afterwards. Okay, you can see the hematocrit levels going down, and you will wonder why. I mean, the cat was eating normally, and the stricture is, dilated, and why do I have hemolysis right now? Why do I have a very, very low HCT? So always think about the refeeding syndrome, especially in cats. Any other questions? Let's see. No. Thank you very much, Justini. Thank you, thank you. Thank you, all of you. And I hope to, at some point, to meet you in person. So, Jason, I think that the audience needs the webinars at this time. Strictures will recur despite repeated esophageal dilations. Yes, unfortunately, they will recur. This is their job, to recur in the initial sessions. But after 6 or 8 sessions, for example, you will have, but every time that they reform, Makram, it will be with a bigger diameter. So yes, they will reform, but never to the initial small diameter that you have. They will reform, but with a bigger, gradually bigger and bigger, increasingly bigger and bigger diameter. So at one point, you will reach up to a diameter that is acceptable for life, and that is acceptable for consumption of either solid food or even canned food. If an animal, if the diameter does not allow the dry food, some owners are really, really happy to. You saw that in the literature, 30% of the cases will only have to be fed canned food, even after multiple procedures. And it's even worse when you have multiple strictures, when you don't have only one stricture to dilate, because they might, the level of the diameter of the two strictures might be totally different. You might dilate one stricture very well with satisfying diameter, and the rest of the strictures, or the other stricture, with a less diameter, and that's a problem. The next webinar will be end of October. End of October, we will have the next one. And we will see what it will be. It will probably be about colonoscopy. Now, we're going to go to the large intestine. And I always want you to know endoscopic procedures, but in liaison associated with internal medicine, because this is what you're going to see in practice. This is why we're not only saying about endoscopic, we discuss endoscopic cases, but under the prisma of internal medicine as well. Thank you all. Have a great evening.
Thank you. Thank you, Dr. Vasiliki.
Thank you, Jason. Thank you very much. And we'll talk next month.
Yeah.
And please give all the participants my email, whoever wants. I will probably write it in the Q&As here. Can I write it in the Q&As?
Yeah, I can write it, and
please write it.
Yeah, I want to say that every attendees will receive the record of today's webinar. And if you haven't received it in 1 month, you can contact me. Okay. So it will be sent it by our distributor in your region.
Very good. And please share my email for people that will
I can
want to. Makram, your Greek are so much better than my. Where are you from? Thank you. Thank you very much.
If you still have some questions, you can ask. You can contact us from the social media like Facebook, LinkedIn, Instagram. YouTube?
Yes, definitely. And we have to highlight, Jason, that you also have webinars in Spanish. So for those of you who are Latin origin, if you want to listen to experts in Spanish, in Latin languages, then Alha offers also these webinars. And the next one is when? On the 11th of October or 14th?
The
Let me
next
check. Let me check.
next is October 4th.
October 4th,
Yeah.
the World Animals Day, which is a
Yeah.
very, very good choice.
So close. If from Latin, speak Latin, you can come
Yes, October 4th.
yeah,
Okay,
you can come to our Latin webinar. It's okay.
that's great.
Okay.
That's great.
Okay. Thank you.
Okay, have a nice evening, everyone.
Thank you,
Goodbye.
Dr. Vasiliki.
Goodbye.
Goodbye.
Goodbye. Goodbye, everyone.
Bye.
Hi, Jason.